Hi everyone, thanks for joining us today here at Chem's office. And in an effort to continue some of our conversations with the medical directors, we are going to talk a little bit about push-dose epinephrine here today. For many of you who I probably have not had the pleasure of meeting before, my name is Dr. Lindsay Rausch and I am the Assistant Medical Director here at Chem's and have been here for the past year. So we really appreciate you tuning in. We're going to try to make this as brief as possible, but I think we have a lot to kind of talk about when it comes to push-dose epinephrine. Really our big why, where did this come from? So in doing our monthly ACS reviews, we were specifically focusing on cardiac arrest patients and those patients who maybe had repeat cardiac arrest and what we could do to potentially prevent this or improve our outcomes with regards to that. In our push-dose epinephrine protocols, and specifically found that we probably have a little bit of underutilization here in Kent County. And this brought up the question as to why. So before we delve too far into the specifics, let's just discuss a little bit about the history of push-dose epinephrine and maybe when it was introduced into our system. So going back to 2018, there was a statewide update on protocols, and this was one of the new protocols that was included. You can find it listed in two different places. It's both under the shock protocol and then also in the ROSC protocol. So now that we know it's been available since 2018, the question kind of came up like, why do we think that we're probably not seeing as much of it being used here in our system? While we thought that we could probably dwell on this here at Chem's and speculate and maybe come up with our own hypotheses, we thought it might be more beneficial to talk to you guys, some of our providers. So we were actually able to arrange a meeting between ALS providers from all of our transporting agencies and kind of just have a very candid discussion about what we thought some barriers might be to this push-dose epinephrine. So we were fortunate to have representation, as I mentioned, from multiple transporting agencies and found that the reasons for less push-dose epinephrine usage were probably multifactorial, as I think a lot of us suspected. Some questions that came up were, was our minimal usage here because we didn't know that push-dose epinephrine was an option? Were we maybe a little bit unfamiliar with the indications for its use and what scenarios we might find it beneficial in? Maybe it was the fact that in the actual process of it, drawing up the medication, diluting the medication was confusing or people weren't as comfortable with it. And finally, after some more in-depth reviews, we also found that maybe the protocol itself was a little bit confusing. If you feel like you could agree with any of those statements, then you definitely aren't alone. So for attempts at some clarity, let's talk a little bit about what types of patients specifically benefit from push-dose epinephrine. I think a lot of our focus today is going to come kind of in these not only suspected cardiogenic shock patients, but even more specifically the ROSC and rearrest patients. Ideally, we're trying to prevent that rearrest scenario, again, as I mentioned earlier. And those cases specifically where you start to see the heart rate downtrending, you maybe start to see the blood pressure downtrending as well, this could be the perfect indication for using push-dose epinephrine. Specifically, when we talk about cardiac arrest patients and then obtaining ROSC, I want to highlight that 10-minute window where we are really encouraging providers to stay on scene. I think this comes as a little bit of a counterintuitive response for us because we want to get this very sick patient to the hospital, but there's actually been a lot of really great research in EMS that supports what we are doing in those minutes matter on scene with that patient in order to stabilize the patient, and again, going back, trying to prevent that repeat cardiac arrest. In that 10-minute time frame, I think some important things for us to do are getting the patient actually into the ambulance and getting prepared for transport while you have additional hands there to potentially help you with that. But beyond that as well, doing things like obtaining that 12-lead EKG, getting that first set of vitals, the blood pressure specifically, and then I encourage you to really kind of add on to that in your mind, maybe this is a good time to prep and prepare some of that push-dose epinephrine. You have multiple people on the scene with you, you're not in the back of the ambulance potentially, and you might just give yourself a little bit more of a window to have that ready if you do need to use it. So as we discussed push-dose epinephrine use a little bit more with some of our EMS providers, we also found that the protocols themselves were confusing. Specifically, we noted that the protocols were written in a way that required push-dose epi after a fluid bolus. Through our case reviews, especially those where we were talking about ROSC, We found that simultaneously administering fluids in both push-dose epi could probably be beneficial for these patients. Moving forward, we are continuing to work on improving our protocols to make it easier for all of our providers. So we're interested to know, have you had challenges with push-dose epi or just anything else? Did we maybe miss something in this short review that you think would be beneficial for us or maybe your colleagues to know about? Have any other suggestions for future conversations with our medical directors? Let us know. Thank you for all you do, as always, for our patients in our community, and a major kudos to anyone who has made it this far in the video. We appreciate you.
Hi everyone, my name is Matthew Caruso. I'm going to be showing you today how to draw up and administer push-dose epi. Push-dose epi can be found in the Ross protocol and shock protocol. The equipment that you will need is either a 10 cc normal saline flush or a 9% solution IV bag. You will need a 10 cc syringe, a 3 cc syringe, an epinephrine 1 to 10,000, and a 3-way stopcock. So what we would do is we would begin with attaching the 3-way stopcock to your 1 to 10,000 epi syringe, and then also attaching your 10 ml syringe. You would draw up a total of 1 ml of fluid. And then you would attach this to your normal saline. And at this point, you'd be drawing up 9 mLs of normal saline. This makes your solution of epi 1 to 100,000, 10 micrograms per ml. At this point, we would take a 3 cc syringe, connect it. We would draw up between 1 ml and 2 mLs, or 10 to 20 micrograms for administration for the patient. We'd administer this as our first dose, and then we would do corresponding doses every 3 to 5 minutes to a titrated blood pressure of 90 systolic. An alternative way to draw a push dose epi is take a pre-filled syringe or flush of normal saline of 10 mLs, push out 1 ml using your 1 to 10,000 epi and a 3-way stopcock once again, drawing up 1 ml of epi, which gives you again the same concentration of 1 to 100,000 of epi with a 10 microgram per ml solution. The administration would be the same as it was in the previous section.